Hisham, President at Department 14, Professor Dr. Hisham Fathallah. My topic is about a heavy gastric pregnancy under supervision of Professor Dr. Sharif Kamal. Our case is 25 years old female patient, primary gravid 17 weeks by date. She is medically free, presented to emergency by severe subacute progressive headache for 20 days associated with blurring of vision, nausea, and vomiting. Her vitals are normal. Ophthalmological consultation showed severe papilledema in both eyes. MRI and MRV were done, and she was admitted in neurology department and diagnosed as idiopathic intracranial hypertension. Her MRI and MRV are normal. Ophthalmological examination on admission showed best-corrected visual acuity was 618 in the right eye and 612 in the left eye, and her fundus examination showed severe papilledema in both eyes. Perimetry shows bilateral tubular field with fair reliability indices. She was managed in neurology department with serial lumbar puncture every other day. The first time, the lumbar puncture opening pressure was 620 cm2 and they withdrew 25 milliliter. The next time, the opening pressure was 600 cm2 and they withdrew 25 milliliter. The third time, there was a good opening pressure, which is 240 cm2, and they only withdrew 4 milliliter. But they had concerns about if acetazolamide could be given during pregnancy or not, if shunt is safe during pregnancy regarding the risk of general anesthesia. So we'll discuss the management of idiopathic intracranial hypertension on pregnancy dependent on the studies of the past literature. Our goal of management is to improve symptoms, mainly headache, and to preserve vision. The medical management requires a team approach involving the patient's obstetrician, neurologist, and also ophthalmologist. In pregnancy, diet and weight control is very important using a non-ketotic diet with moderate salt and caloric restriction. And medical treatment, the first thing is acetazolamide. It's the mainstay of medical therapy for idiopathic intracranial hypertension. However, there are limited data discussing pregnancy and offspring outcomes among acetazolamide users, so the reluctance to use it in pregnancy is not surprising. By reviewing literature, there is one of the studies that explains the use of acetazolamide during pregnancy in intracranial hypertension patients. A total of 101 pregnancies consented, and acetazolamide was used in 63 pregnancies, and the use of medication before 13 weeks of gestation were reported in 50 pregnancies. 13 weeks was used as a cut-off level as it represents a teratogenic period. The results showed that the abortion rate wasn't statistically increased among acetazolamide users, and birth abnormalities in patients treated with acetazolamide before 13 weeks included one child with asthma and reactive airway disease, one child with cerebral palsy, and another one with hydronephrosis, craniosynostosis, and juvenile rheumatoid arthritis, heart murmur, and esotropia. One with mild external ear malformation was born to a mother with acetazolamide before 13 weeks of gestation. However, no case of forelimb or other axial skeletal malformation was identified. But also abnormalities of similar severity were reported in 16 children of the control group, including seizure disorders, heart murmurs, asthma, hydronephrosis, ADHD, and speech delay. So, our conclusion, acetazolamide is a category C medication in FDA classification in pregnancy. Category C means that the teratogenic effect is proved in animals but not in humans, so it should be used if the benefit outweighs the risk. And the teratogenic potential of acetazolamide has been established in rats, mice, hamsters, and rabbits producing limb malformations. No such effect has been found in monkeys. The teratogenic was produced during early pregnancy when dosage are used with several times more than that administered in humans. Human equivalent dose to 60 to 80 milligram per kg using the body surface area formula. There is a single case of sacrococcygeal teratoma in an infant born to a mother treated with acetazolamide until the 19th week of pregnancy. However, the authors state that we do not propose a cause-and-effect relationship between the maternal use of acetazolamide and the development of that uncommon tumor. Other opinion in the medical community adopted the recommendation to avoid use of acetazolamide in the the first trimester of pregnancy. However, acetazolamide is not a confirmed teratogenic agent. There are alternative diuretics that can be used in treatment of idiopathic intracranial hypertension, including loop diuretics. However, it's also a category C medication and shouldn't be used chronically during pregnancy. Thiazide diuretics is classified as category D for the fetal risk and should be avoided in pregnancy. Corticosteroid is recommended but used only in the presence of significant visual decline and only for a short time. Analgesics is used for the treatment of headache. Propranolol and topiramate for prophylaxis of headache in patients with idiopathic intracranial hypertension. Propranolol used over many times without teratogenic effects, and it's believed to be associated with fetal growth restriction. However, such complications were very minimal. Topiramate, being a chronic carbonic anhydrase inhibitor, it may add to the effect of acetazolamide. However, information about safety in pregnancy is limited, so it's not recommended for pregnant women. Another modality is repeated lumbar puncture and spinal drainage. It's not contraindicated in pregnancy. It's helpful in improving headache and also showed improvement of vision. However, this modality has never been systemically studied for the treatment of idiopathic intracranial hypertension, and some authors believe that they shouldn't be performed therapeutically except in pregnancy. Our indication of surgery, intractable headaches, so shunt can be performed. If there is significant visual dysfunction that doesn't improve with diet or medical treatment, and evidence of progressive nerve fiber bundle dropout or active disc failure, optic nerve sheath fenestration is recommended. And in case of malignant intracranial hypertension with rapid visual loss, both shunt surgery and optic nerve sheath fenestration is recommended. Back to our case, the decision at the Neuro-Ophthalmology clinic was to give full dose acetazolamide and follow up the patient weekly. 1 week later, after examination, her vision improved to 6.6 in the right eye and 6.9 in the left eye, and the papilledema is resolving. Fundus photo. 2 weeks later, the vision improved to 6.6 in both eyes, and papilledema is also resolving, and the decision was to continue on acetazolamide and withhold lumbar puncture for 1 week. Her new fundus photo showing improvement of the papilledema. Perimetry was done. In the right eye, it showed enlargement of the blind spot and incomplete upper arcuate scotomas with upper nasal stippling, lower and nasal paracentral scotomas of moderate significance for follow-up. Also, in the left eye, there is enlargement of the blind spot and nasal field defect with nasal stepping larger superior. This perimetry is more reliable than the first one. There is another similar case with different management and prognosis. She's a 32-year-old female patient presented to the Neuro-Ophthalmology clinic with progressive bilateral diminution of vision over the last 12 years. She has a history of papilledema dating since first pregnancy 12 years ago. She sought medical advice and refused medical treatment and lumbar puncture. Her course was stationary and she's medically free. By examination, the best corrected visual acuity was counting fingers 1 meter in the right eye and counting fingers 30 centimeters in the left eye, and fundus examination showed severe optic disc failure in both eyes. Her fundus photo. MRI brain showed demyelinating empty cerebrospinal and increased perioptic CSF spaces suspecting idiopathic intracranial hypertension. Her perimetry shows severe functional optic nerve damage, contracted vision with poor reliability due to poor visual acuity. Her fundus photo show fundus fluorescein angiography show bilateral post-papilledemic optic action. So by comparing our two cases, the first one was compliant to medical treatment and lumbar puncture, and her prognosis is good and papilledema is improving. However, the second one refused treatment and she ended up with post-papilledemic optic action. Take-home messages. Pregnancy occurs in idiopathic intracranial hypertension at about the same rate that pregnancy occurs in the general population. Idiopathic intracranial hypertension can occur in any trimester, however, it usually appears in the first half of pregnancy. Patients with idiopathic intracranial hypertension during pregnancy have the same spontaneous abortion rate than the general population. And visual outcome for pregnant women with idiopathic intracranial hypertension is the same for the women who are not pregnant. The pregnant patient should be treated the same way as any other patient with some contraindications. Therapeutic abortion is to limit progression of the disease is not indicated, and subsequent pregnancy doesn't increase the risk of recurrence of idiopathic intracranial hypertension above the risk of recurrence in any other woman associated and is associated with normal outcome. Special thanks to Dr. Shema Abdel Salam and Dr. Ragda Mahmoud. Thank you.